I'm pleased to welcome Dr. Naomi Fried from the Boston's Children's Hospital to our studio today. And I wanted to ask her, really fostering a culture of innovation, is it different in the healthcare sector versus other sectors? Dr. Fried, what do you think? Have you been able to determine whether there is a different situation in healthcare?
So I think that healthcare is fundamentally a very complicated landscape to be innovating in, given that it's basically a three-party payer system with the patient, the provider, and usually the payer. I think the way that you innovate internally within healthcare is different, and I've developed the Innovation Lifecycle to explain how that happens. It's really 6 steps and a gap in terms of how innovation happens within a healthcare organization.
Mm-hmm. What are the 6 steps, and how were you able to identify that these are the correct ones?
So to answer the second question first, it was sort of I identified how the life cycle worked by sort of watching and working with innovators over many years. I was the Vice President of Innovation at Kaiser Permanente and developed their innovation program. And so it was sort of looking at, well, what's happening to all of these innovators and where are they? And so the paradigm that I've developed is the life cycle starts with initiation, where you identify a problem. And this can be at the strategic level. The organization can identify a problem that they want to innovate around, or it can be on the grassroots, on the front line. You know, a doctor or nurse thinking about something that they want to see done differently. Once you initiate innovation, then you go on to the ideation phase, and that's where you're starting to come up with different ideas that might work or might solve the problem you're working on. At the end of the ideation, you sort of harvest your best idea and move into the pilot phase, where you're actually going to try things out. And this is a phase where if you're going to fail, which happens a lot in innovation, it's going to happen in the pilot phase. If you have a successful pilot, in the ideal world, the next step would be operationalization, meaning everyone in the organization will start using your great new idea. But what we found in the real world is you can't go directly from pilot to operationalization. There's actually a gap or a chasm there. And so I coined the term the operationalization gap, or O-gap, to explain that diffusion barrier or chasm that you often find. And so if you can get across the O-gap, then you're on to operationalization, where the whole organization experiences the value of the new innovation. And that's not the end, though. There's 2 more steps. The next one is optimization. So that's where there's sort of local innovation happening by the end user of the innovation. And the last step is obsoleting and potentially repeating the process again. And that's sort of recognizing that what was a great innovation is not meeting your needs anymore. Could be because workflows change or because there's new technology, and so you need to actually start the process over again.
Or obsoleting, which means just
throwing
out the idea. How often do ideas fall into the O-gap, that chasm there?
Yeah, so again, ideally you get across the O-gap and you don't lose the innovation there, but I think without recognition of the O-gap or an understanding of that challenge, that a lot of things do get stalled out, and that they just end up as small local successes rather than as institutional successes. So there's a number of ways you can close the O-gap, you can get across it. Sometimes what you need is leadership sponsorship to re-engage and get everyone involved. Sometimes you need more funding for change management. Sometimes the O-gap's actually technical, so you might have built a prototype that worked very well for 5 or 10 people, but now you want to scale it across the enterprise, and you can't just do that, so you have to actually rebuild it. But I think probably one of the most significant ways of closing the O-gap is actually knowing that it's coming and planning for it. And the advice I give the innovators that I work with is to actually get the folks who would be involved in operationalization, involved in the life cycle earlier, get them to work with you when you're initiating, when you're ideating, let them know what's happening in the pilot. And that will probably do more than anything to shrink that O-gap and make it possible to actually get across.
Are there any real life examples that have gone through all 6 steps that you can point to?
Well, I think most successful innovations that we use now started that same process. Even if you take something that we take for granted now, such as the electronic medical record, at one point that was an idea. It was initiated, tested, piloted. Someone had to figure out how to do it on an institutional level. Certainly, it's been operationalized, at least at our hospital, and now it's being optimized. And I hope we're not going to obsolete our EMR, but it could happen, and we could decide that there's something better or it's not meeting our needs. So it's a very common life cycle for internal innovation.
So in a way, EMRs are still in that life cycle. The jury's still
Absolutely.
out on whether they can close the book on improving that. Or.
And I think different organizations are in different places, even with their innovation life cycle for EMR. Some of them are just testing them out and haven't fully operationalized them. Some of them are optimizing, and there's certainly situations. I know when I was at Kaiser, we went through 2 or 3 EMRs before we finally settled on the one that is in use now. So it's not also uncommon sometimes to have to try again.
Okay, wise words. Thank you so much, Dr. Fried.
My pleasure.
I'm Mabel Jung at the World Healthcare Congress 2012.